My name's Neil Smith. I'm a GP in Blackburn, and I've got a particular interest, some would say a passion, on early diagnosis of cancer. And what I'd like to talk about is the new NICE guidance for suspected cancer, the recognition and referral. This guidance came out in June 2015, and it's been a real challenge for us working in the cancer field to implement these changes. And what I've realised is the reason for this challenge is there's a series of interconnecting themes that need solving together. And what I've managed to do is to define 8 key elements which I've put on what I'm calling the cancer implementation wheel. The first issue that needs addressing is about demand modelling. The problem is there's no national guidance here. There's no scientific formula that you're going to find. What I've realised, it needs conversations and a common sense approach to solve this. It's about people, commissioners and managers and clinicians getting together, considering the impact of the NICE guidance on their local health economy and trying to predict the future. There are also several solutions already emerging nationally. So one suggestion is to steal other people's ideas and see how that applies to your locality. The second important issue is to try to redesign pathways. Now I see this as a major opportunity of improving things, of streamlining processes, bookings and appointments to make that better for patients. Because in the next 5 years, one thing that we'll all have to achieve is the Achieving World-Class Cancer Outcomes target, that 95% of patients referred on a cancer pathway have a diagnosis within 28 days. And the only way we're ever going to do this is to reconsider and redesign the pathways that we currently have for cancer. The third element is about creating new referral forms. On the one hand, this can be quite simple. You could use an old form and then edit in the new guidance to update it. There's also an opportunity here to make the referral forms better by using IT solutions to populate clinical information for the good of the patient. But one thing that I've realised is a lot of people have got a lot of opinions, and it does need a lot of conversation and meetings, particularly between GPs and consultants, about the content of these referral forms. And the problem is they have to reflect a local pathway, so there's not going to be any national solution and a one form fits all across the country. This leads on to the fourth issue, which is access to urgent investigations. We already know there's considerable variation across the country for GPs to be able to access investigations. The new NICE guidance tries to standardise this, but what it will mean, it will not only increase the number of referrals, but increase the turnover of acting on these referrals. And also, NICE guidance is quite clear in the responsibility for tests. So, for example, if a GP does an investigation, they're responsible for acting on the result. It has to be imperative that any changes we make involve patients, and patients have got to be at the centre of these redesigns. And what I've found to huge advantage is collaborative working with patients. Ultimately, patients have got to understand these pathways. We've got to create patient collaborative information about them, and we've got to get feedback from patients about their views and their satisfaction and act on that feedback. With regard to GP education, there's already a growing number of resources out there for GPs to use. But the important issue is how we can help GPs universally adopt this and help them in the change management process to do so. And one important issue is to have a range of different learning resources which fit in the needs of different GPs, be they education events or e-learning materials. Another major issue is about financial and workforce planning. there's going to be major impacts on health economies with increased workload, increased costs, need for training, need for equipment. We've also got to consider the impact that these cancer services have on other health services within a health economy, and that demand that puts on primary and secondary care. And the final issue is about increasing capacity. And what I'd firmly recommend is a clear strategic plan, including workforce, estates and finances. From my experience, what I've learned is that you're better to solve the easy wins first. You're not going to manage to do a big bang approach. It has to be phased, and you've got to have decent, reasonable timelines that you can achieve these changes in. So when you put the wheel together, you realise that you can't unravel one element in isolation. So for example, you can't put on GP education events without being clear of, do you have access to the investigations? You can't rewrite forms without having the pathways in place. Each of these elements really need to be worked on synergistically with a clear plan to do so. And they have to be done together. It's about collaborative working. It's about people getting together and discussing it. And those final decisions can only be made in local health economies. There is not going to be a national solution here. It's about people in localities who have on their roles the cancer agenda, trying to solve this together. So in conclusion, implementing the new NICE guidance for suspected cancer recognition referral is a major challenge that we're undertaking at the moment. I hope that by defining these 8 key elements to work on helps you. What are we doing this for? Don't forget, the important thing here is what we're trying to do is diagnose cancer earlier and save patients' lives.